It's free. Give it to a kid who's got any work of breathing, even if their pulse ox is normal. Giving oxygen helps them with their work of breathing. So even if it's just a whiff, a little bit to help, it helps. When we're getting to a BVM ventilation, we're in trouble, aren't we? Mm-hmm. Now we're assisting ventilation. I'm standing there forcing that child to breathe. That usually means we're headed to intubation, right? We might have, a cardiac tamponade where we have to stick a needle in to draw the blood out. They need IV therapy. You'll find this is a common in almost everything we're going to discuss today. They need fluids. Blood products. Frederick County is one of the only EMS in the state of Maryland that has whole blood products on their units. This saves lives. You've heard, I'm sure, even in social media about the golden hour. Well, when you can give blood in the field, that extends that time a lot, okay? This is a volume expander. Think about people who are bleeding internally or having actual blood loss, right? Cervical stabilization needs to happen with any kid who drowned, who fell, who was in an MVA, a bike accident. We need to make sure their neck is okay. I can't tell you how many times we've gotten MVCs in with this on. They go over, they come back from their CAT scan and they have like a C2 fracture, and you're like, what? And then defibrillation and synchronized cardioversion. We'll talk a lot more about those. Lots of medications are used, aren't they? We've got adenosine, which we use for supraventricular tachycardia. Amiodarone works really well for ventricular ectopy, dysrhythmias. Atropine is our go-to drug for bradycardia. You'll find more in children, though. We give atropine for bradycardia as our front line. Dobutamine helps with shock by increasing your heart rate. Dopamine, we give that often for bradycardia, hypotension, and shock. Epinephrine or norepi drips increases your heart rate, so we give that for bradycardia, anaphylaxis. Most shock or real stressful situations that the body goes through cause a hypoglycemic state. So we always check their AccuCheck. Anybody critical gets an AccuCheck. Do they need more glucose? Then lidocaine works really good for ventricular ectopy or dysrhythmias, and naloxone is for your narcotic or opioid ingestions, right? So lots of drugs we give in critical care situations. So clinical judgment is really critical in dealing with critically ill children. You've got to be able to trust that gut of yours. As a nursing student, you're starting to kind of identify that you have a gut instinct, when you go to the bedside and you're like, oh, that person looks okay, or that person looks really sick, or I don't like the way, right? That's your gut instinct. So you need to really fine tune your gut over time, because when you're standing at the bedside, a lot of times you will have that sixth sense, right? That's your gut. So looking at your ABCs, getting a health history. You think of like a hypovolemic shock, your health history is going to be really important. When did the vomiting and diarrhea start? How many days ago? How many times do they vomit in a day? How many diarrhea stools do they do in a day? What weight loss do they have? Do they have urinary output? Do they have tears? What do their mucous membranes look like? What is their cap refill, right? Lots of things that we need to do in that physical assessment. A, B, C, always going to be at the top of the list, right? Because if you don't have an airway and you're not breathing, the rest just doesn't matter, right? But then we need to look at our neurological evaluation. We're looking at their alertness, if their verbal response, what they feel about, and we keep doing that reassessment. And then skin, extremities, what, if anything, is wrong with those as well. We had a guy, Miller was showing me, he was ejected from a car accident this week, and he had degloved his leg on the guardrail. Who saw that with me? He died. He died 2 days later. So anyways, EMS found him sitting on the side of a guardrail, and he had taken the skin and just completely, so his whole thigh was exposed. And they had to take the flap of skin and pull it back up to transport him. So they tried surgery, and it didn't work, so they had to amputate the leg, and he died 2 days later. So, yeah, extremities, check them, right? Bad things can go wrong with them. When you're opening the airway for a child, there's ways we do that. Those of us who saw synchronized cardioversion this week in clinical, right?
Dang,
He had an
you got all the
interesting
good
airway.
stuff.
Oh man, I'm telling you, look out, right? So we were just kind of walking out, taking a tour, and they're like, we're going to do synchronized cardioversion. I'm like, I'm going to lecture about that. We want to see that. So it was interesting. It was this 67-year-old guy who'd had AFib RVR who needed to, get out of it because he was having some heart failure. And like he said, I want to protect my heart. I don't want to have heart failure.
I had that patient. Was it 200 joules?
Mm-hmm.
I had that patient on telly.
He was a really nice guy.
Yeah.
His wife mapped the human genome.
Oh, really? I didn't get that
Oh,
much.
yeah. I was kind of like, you did what? Underachiever. Anyways, so before we gave him propofol to sedate him for the moderate sedation, the doctor said, do you have any issues with sleep apnea? And he goes, yeah. So he goes, okay, open your mouth and say, ah. And he goes, oh, yeah, I can see that. So we knew going in that he may have airway issues because of that. So sure enough, we're looking at his end-tidal CO2 of 7. We're like, whoops, that's a problem, right? So, what the nurse did was just a head tilt chin lift and just kind of opened up and extended the airway, and it popped right back up to like 28, 30, 32. But then he had to stand there until the guy recovered, because the minute he'd let go, he'd drop it again. He had airway compromise, so he's not a great person to sedate. Luckily, kids don't have sleep apnea for the most part. But opening the airway is important. You guys are all CPR certified, aren't you?
Yep.
You ready to do CPR on a kid?
Yep.
Yeah. So let's talk about it. Let's talk about doing CPR on a kid, because we do things differently when it comes to CPR. All right, so checking for a pulse. As you remember, no more than 10 seconds, right? We can't dilly-dally over there going, do you feel one? I don't know. Do you? I don't know. Let's talk. Right? It's got to be quick. Child, carotid femoral, infant femoral, brachial. Evaluate and manage the airway. This is critical with a child, because most of what the problem is right here. They've lost an airway. Think about this, and this will remind you of what we talked about when we did peds cardiac. Remember what I said? Kids born with healthy hearts should never go into cardiac arrest. It's going to be pulmonary that causes them to go into cardiac arrest. So if you fix the pulmonary problem, you're going to stop the cardiac arrest. Okay? But if you ignore that pulmonary problem, it's going to go right into cardiac arrest. And it'll go, I'm maintaining, and then I get tired, I crap out, and I arrest. They go apneic. Okay? So evaluate, manage the airway. You may be able to fix it. Okay? If you're still struggling, you still call for help. If you're outside of the hospital, you get an AED, right? And then you start CPR. Do you know that we start CPR when kids have a pulse? Okay, we'll talk a little bit more about that as well. I put a CPR question on an exam a year ago, and 50% of the class got it wrong.
That question?
No, a question. I thought it would be a gimme, because I thought you all CPR certified.
That certification is not good.
Yeah. So, when do I start CPR, right? So, are they breathing? What's their color? What's going on, right? Do they need rescue breathing? Maybe, right? If their pulse is greater than 60, but abnormal breathing, we're going to probably call CPR. If it's witnessed, we start CPR using AED, shock when prompted. So it's important to know your algorithms, right? I carry them in my pocket at work. Here's the PALS algorithm for a single user CPR. These come in cards, right? Verify scene safety, right? You don't run into somebody who was just electrocuted and then get electrocuted yourself. Check for responsiveness, shout for help, activate EMS. Look for breathing or for ongoing gasping. Check for your pulse. right? If it's definitely not felt within 10 seconds, we're going to start CPR, okay? After 2 minutes alone, we're going to leave and get an AED and come back. Check, is it shockable? No, and you continue CPR. Yes, you're shocked. Check a pulse, begin CPR. We have to know what we're doing when we're dealing with people's lives if they're dying. These are the key updates to PALS in 2025. I thought they were pretty interesting, so I wrote them out for you. The traditional 15-2 ratio for pediatric CPR stays in place unless you're using the valve mask or they're intubated. Then you do 30-2. You want to minimize any time off the chest, okay? So that's showing that minimizing the uninterrupted chest compressions enhances coronary perfusion. Next one, the updated guideline now recommends for every 100 beats you press on the chest, you give epi. 100-to-1 ratio. Okay? So every 100 compressions, they get epi. It used to be every 5 minutes. Okay? But in kids, it's every 100 chest compressions. Team dynamics are critical. You cannot operate in a dysfunctional team and save a life. Okay? So they recommend a 5-to-1 leadership to team member ratio. One boss, right? 5 people working for him. Okay? The structure helps. So what do I do if I'm medication nurse? I get a label on my chest. As I'm giving the med, I'm shouting that out. Epinephrine is in, right? Lidocaine in. Fluid bolus in. Whatever you're doing, you're shouting out. Clear communication. Post-resus care now is calling for ongoing assessments. These are super important. Conducted at a 60-to-1 ratio, so you're tracking that patient systematically. So this allows you to determine if there's any deterioration in the patient's condition and intervene quicker and sooner. And then temperature management and family involvement is very important. I'm going to show you where we bring family in on a code in another slide. But remember, anybody who's coded is cold. They need warming. So how do we warm? Bear huggers, right? All right, defibrillation. The heart does 2 things. It pumps and it has electrical current. Sometimes that electrical current is aberrant, right? It's going different paths. It's causing abnormal beats. It's doing things that we don't like, okay? So defibrillation is when we've got like a V-fib and we're shocking, right? We've got a shockable rhythm that we're trying to get back into a normal sinus rhythm, okay? That's often given with oxygen, CPR, and medications, right? We're given CPR, we get a V-fib, we're like, oh, that's a shockable rhythm, everybody clear, boom, shock, right? That's defibrillation. Synchronized cardioversion is we need to plan it. We don't want it just to occur anywhere on the QRS. We need it to fall on the R. Because if it falls anywhere else, it can send them into VTAC, VFib, and death, okay? So this is another way of giving electrical current, but it's delivered in a synchronized fashion, applied on the R wave. So, what rhythms are shockable? You ready to tell me what some of these are? VTAC. Anybody agree?
Yeah.
What makes it VTAC?
The bees.
Wide complex, regular rhythm, no P wave. That's VTAC. Do I defibrillate that or do I synchronize cardiovert that?
There's no R wave to synchronize.
I'm not sure I understood the answer. Do I defib or synchronize? I got a regular rhythm. I'm going to sync that. What am I? What's it look like the heart's doing?
Fluttering with PAC.
You're right. What's the rhythm before death? V-fib. All right, V-fib. Easy to remember. The ventricles are just going like this. See that? Okay. No perfusion's taking place. Am I shockable? Hell's to the yeah, you better shock that. What am I? Am I regular? Yes, I'm regular. Okay. You see a P wave? Where do you see a P wave? Are you calling this a P wave? Because you're wrong.
Then it's AFib.
Is AFib regular or irregular?
AFib's were.
The question is AFib regular or irregular? It's what?
It's irregular.
It's irregular.
Yeah.
That's a regular rhythm.
Oh, okay.
It can't be AFib.
Yeah, valid.
SVT.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
Oh, super SVT?
SVT.
Yeah. SVT. Gotcha.
Am I shockable? Am I defibrillated or synchronized? You got a regular rhythm. You better synchronize that. Okay? What am I? Am I regular?
AFib.
AFib.
Now you're in AFib, yeah.
Now you're in AFib. Am I shockable?
Yeah.
Do I defib that or do I synchronize that?
You defib.
Did somebody say you defib that?
You defib it. No?
You
AFib?
synchronize cardioversion.
What?
Oh.
If we defib that, we're going to be into probably this. So regular rates synchronize, and AFib is a synchronized cardioversion, okay? So this is what synchronized cardioversion does, okay? You go over to your life pack, right? You've got your patches on your patient. I think where my patches go, right? Under my arm and on my chest. I got my patches. They're connected to my life pack. I go over and I say, oh, I got a cardio over this person, and I'm going to press the button. What button do I press? You got it. That doesn't even work. So you press the sync button. I thought I came prepared today because I can't stand having markers where they all go. All right, so it'll just look like this, right? The little sync button. It doesn't say synchronized, it says sync. I press that button and these carrots appear. They're called carrots. That's why I put them there. Okay? Now that's telling me my sync is ready and I am ready to hit my button to defib. And now I can come over and hit deliver joules and that patient will get shocked. But they're going to get shocked on the R wave because of the carrots. Remember seeing that, Lauren?
Yes.
Okay? If I don't press the sync button, those won't appear. So part of my job, if I'm on the life pack and the defibrillator, is the doctor will say, did you hit the sync button? Yes. Do you see the carrots? Yes. Are they lining up? Yes. Are we ready? Yes. Everybody clear? Bing! Boom! Right? That's exactly what happened.
Is that painful for the patient?
Yeah. Well, that's why we gave him propofol.
Oh, yeah.
We wanted him to be unconscious for it, and he was for the most part, but, you know, yeah. Getting shocked with 200 joules was a wake up, right? I'm sure. I wouldn't want it. Initial energy amount is 2 joules per kilo, and it can go all the way up to 4 joules per kilo. That's a peds dose, right? What are the adults? Right? You can start for cardioversion You can start as low as 50 for an adult. 200 is pretty typical for a big size adult. And then defib starts at 2, right? And goes all the way up to 360. So, important to understand synchronized cardioversion. Automatic external defibrillators are these AEDs. They are for out of the hospital setting, okay? They don't work for kids under a year. And you have to have sort of no pulse and suffered a sudden witnessed event. Remember, kids have smaller pads. All right, more rhythms. What do you think I got there?
Sinus Brady.
All right, that's ugly. Looks like mud. Red rum. All right. So why do you think it's sinus Brady?
You got P waves.
You got a P wave.
You got your
for every
QRS.
QRS.
And
You got a nice narrow complex QRS.
Mhm.
And in 6 seconds, you have 1, 2, 3, 4. So your rate's about 40. Should a kid have a rate of about 40?
No.
No. We may be given CPR with that rhythm. What do you think this one is? Let's see if it's regular. Looks regular to me. It's a P, QRS, T, P, QRS, T. All right. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13.
How old was the kid?
Doesn't matter. What's the rates?
What's sinus?
130. Sinus tap. Good job. This is not a block. PQRS, PQRS, PQRS. This is something kids do. It's normal.
Oh, it's with their bridging pattern, isn't it?
It sure is. What do you call that?
Sinus arrhythmia.
Yes! Sinus arrhythmia. So what's happening is right here, this patient's just taking a deep breath, and the heart just goes, oh, okay, and then pop, keeps going. Sinus arrhythmia is very common in children. And if you feel like their pulse, you'll be like, oh, that feels irregular. But it's just a sinus arrhythmia. All right, respiratory arrest in children. We've gone over a lot of this, so let's just talk about a few more things to make sure we know what we're talking about, okay? SIDS is the leading cause of respiratory arrest in children. For 20 years, I sat on the Child Fatality Review Committee, so I know SIDS like the back of my hand. We studied things in the community in Montgomery County to try to impact children's death. We did blind cords, we did screens on apartment buildings, and we did SIDS, lots of things, preventable deaths, right? So what we found of kids with SIDS are some common things. Their cribs were full. They had stuffed animals, blankets, diapers, formula, you name it, it was in the crib, okay? We also learned kids shouldn't sleep on their belly, right? When they're infants, before they can turn over, they can get into such a deep sleep that they just become apneic and die, okay? And so now we put them in straitjackets and they sleep on their back. Have you seen those sleep sets? Yeah, my daughter, when she had Sailor, she's like, oh, I got her a sleep sack. And I'm thinking, oh, so cuddly and cute. And I go down and she's like zipped up in a straitjacket. She can't even move. I'm like, how can she sleep like that? I can't sleep like that. But we've learned, okay? So in the biggest takeaway of anything pediatric related is how important their respiratory status is to their being alive, okay? So they give us all of these things to look at as warning signs. They give us grunting. They give us nasal flaring. Head bobbing. Tugging. The tracheal tug. Retractions, accessory muscle use. Wheezing. What's that? Strider. Okay. They give us so many warning signs, right? Increased work of breathing, tachypnea, hypoventilation, so they're hypoxic. Periodic breathing, have you seen that with infants? You try to count their respiratory rate and they stop breathing and then they're like, you're like, calm down, I can't catch your rate, right? Apnea is very common. Apnea in infants is a sign of impending respiratory failure. Nasal flaring, head bobbing, retraction, stridor, drooling, cyanosis, hypothermia, hypoxia, restlessness. Lots of signs that they're going to die if we don't interact with them in some way. So we have to figure out what's causing this to avoid arrest, okay? So most of that's the airway, oxygen, monitor for changes in their status, and most of it's all going to be that. And then if we have to, we assist with ventilation. A lot of times you can prevent a cardiac arrest in a child by doing bag valve mask ventilation, right? You're correcting the problem. So their heart's like, oh, okay, let me beat a little faster. You're not going to stop breathing on me, okay? So respiratory arrest is a big deal. We have to know. So just look, this infant, because of their big head, they occlude their own airway just lying flat. That's why we put like little pillows under their neck. We open their airway. Sometimes we do a modified jaw thrust technique where you kind of stand up here and lift open to help clear the airway. And then bag valve mask ventilation. This is a kid who's not ventilating well, right? So you're going to ventilate for them before they become apneic and get too tired. This usually leads to intubation, right? So correct bag size. Remember, we got newborn, child, adult. We connected to oxygen, 10 liters for infants and children, 15 for adolescents. You guys already know the importance of a good seal with your hand placement. You observe the chest rise. You observe change in color. You observe the pulse ox going up. You look at your end tidal CO2s. A breath every 3 to 5 seconds. Right? All right, shock. I know, whiplash. All right, so with shock in a child, something major is going to happen, respiratory or cardiogenic in some way. So kids with cardiogenic shock usually have a heart defect. Kids with hypovolemic shock, how do you think they get that?
Bleeding, anaphylaxis.
Hypovolemic shock. Dehydration and blood loss. Anaphylaxis is a distributive shock. I'm going to teach you that.
But don't all the blood vessels dilate, which makes it hypovolemic? Because
Yeah, but you don't have a volume loss. That's what's crazy about it.
Okay.
So, hold on. All right, so you've got this hemodynamic compromise, right? Remember, the kids have a small cardiac output. Okay, they just don't have little heart, little output. Okay, so if we're impairing their cardiac output, they're going to have signs of shock pretty quick, aren't they? All right. So infants have a small stroke volume. The cardiac output depends on their heart rate. So now, if they're super tachycardic or bradycardic, right? So we have compensatory mechanisms, right? This is the body trying not to die. This is the body going, I'm going to send you so many symptoms, and I'm hoping somebody's going to figure this out. I'm going to maintain it a little while by being tachycardic, by being tachypnic. I'll try to maintain my blood pressure for a while, but if you're not going to give me fluids or something else, I'm going to drop that to get your attention, right? So the body in kids will hold on for as long as they can, okay? But if you continued with decreased blood flow, you're going to have an issue. So we start shunting, right, to the vital organs, right? So in hypovolemia, if I've got a massive blood loss, I'm going to shunt, go to my brain and my heart, right? So, Then you have this cumulative effect of capillary destruction, vasodilation, tissue ischemia, and now the organs start to fail because they're not getting perfused well. So now you're going to see kidney problems, right? So hypovolemia is the easiest one, most common in kids. This is just where vomiting, diarrhea, diuretics, blood loss, heat stroke, burns, cause of volume loss, okay? Septic is a systemic inflammatory response to an infection, okay? Cardiogenic is an ineffective pump, okay? That heart is just not working like it should. So that's why it's mainly kids that have cardiac defects that have cardiogenic shock. And then you've got distributive, that's a result of a loss of your systemic vascular resistance. And this comes, and this is what we were talking about. You get a relative hypovolemia, but your vascular component expands due to that dilatation. So it kind of tricks your body.
Okay, gotcha.
And so you actually require more fluid to maintain cardiac output despite not actually losing fluid. So that was the tricky one. It's a little more complicated. All right, so what do people look like that are in shock? Think of kids. You ever seen a kid in shock? Good. So a good health history is really important. We need to ask questions like, when did they get sick? How long have they been sick? So even in sepsis, how long have they had a fever? How high has the fever been? Are they eating? Are they drinking? Those are really, really important. You're trying to figure it out. Are they having urinary output? If so, how much? Oh, they haven't peed since yesterday at noon? You're in trouble, right? So respiratory signs of failure. They might be tachypnic, head bobbing, right? Tachycardia. They might have some hypotension, cool pale skin, delayed cap refill, decreased urinary output, sunken fontanelle, lack of tears. Altered mental status in a kid is usually lethargy, right? They're just listless, lethargic. They might be irritable. They have trouble maintaining their body temperature. Might be depressed, more somnolent. And then check for blood loss, right? Because we might be dealing with a hypovolemia related to a blood loss that we're unaware of. Therapeutic management of shock will depend on the type of shock you're treating. Makes sense, right? So like I can't throw a ton of fluids at a cardiogenic shock. I gotta watch my fluids. But I'll throw a ton of fluids at my hypovolemic, and I'll throw a ton of fluids at my septic. Probably even throw quite a few fluids at distributed, right? So, laboratory and diagnostic testing. Blood glucose. When you are fighting an infection or your body's really stressed, you will drop your sugar. Okay? Everybody gets an EpiCheck. Your electrolytes can be off. If you've got a hypovolemic shock, I guarantee you that kid's potassium's low, right? Think of all the things you get depleted of. CBC is super important, especially in our septic shock. Blood cultures, we'll get those pretty much on anybody in shock. CRP, who's that good for? What type of shock? Septic, yep. Lactic acid is for sepsis. ABGs, those are your kids that are often going to be intubated, get an ABG. We might just do a VBG to check our level of acidosis. May need to do a toxicology panel, a lumbar puncture for infection, a UA, urine culture. We might need chest x-rays if we think we got a pneumonia, or sonograms, or CTs. So remember, almost anybody in shock needs fluids and oxygen. It's just a given, okay? So you're assessing their, their ABCs, putting oxygen on, doing vital signs. You get an IV, you restore fluid volume. And then medications will be based on what you're treating. There may be no medications for a hypovolemia. They may need a little D10. Your cardiogenic shock, they might need a few pressors. It just depends on, how severe their hypotension is. Your septic shock, they're probably going to need gent and amp, right? And then your distributive might need, if it's anaphylaxis, they might need Benadryl, epi, and steroids, right? So your medication is going to depend on what type of shock you're treating. But almost all of them require medication. All right, we're going to come back to shock at the end of the class, okay? But shock's important. There'll be shock on the exam, shock on your NCLEX. People die from shock, so it's super important from a nursing perspective that we know what it looks like when we see it in the clinical setting. All right, we talked about this when we went over cardiac week 6, but children typically have a healthy heart and rarely experience primary cardiac arrest, okay? Now, granted, they could be stung by 1,000 bees, they're allergic, and they go into cardiac arrest from the bee sting, right? But that's a cause, right? Normally, healthy hearts don't just suddenly have an arrhythmia like a 70-year-old can, and I don't know what happened, he just dropped dead today, right? That doesn't happen with kids very often. They have to have a Marfan or something wrong with their heart, right? So they experience cardiopulmonary arrest from gradual deterioration, and it's usually right here, or we miss that they're in shock and we're not treating it, okay? One of the kids that died of shock at Frederick Health was in cardiogenic shock in the waiting room, and they didn't realize she was in cardiogenic shock, okay? So it's this part that is nursing's job right here, okay? It's my job to go, oh, I don't like the way things are looking. Your physician's not at your bedside. When I get a patient back from triage and I'm looking at their vitals and they'll be like, everything looks great, but their blood pressure's a little soft. Oh, everything looks great, but their blood pressure's soft, right? So then I'm like, all right, do you have any heart failure? No? All right, I'm gonna get fluids on board right away, right? So you kind of have to watch that deterioration. Your vital signs are your biggest one. Your mental status is another one. You know, if the patient's getting more and more somnolent, you're in trouble. Okay, so just know that cardiac arrhythmias are treated differently for children. Okay, so let's talk about bradyarrhythmias. So your adolescent that's on the track field that's got a heart rate of 50, that's okay. They're healthy. That's normal. Okay. Your 9-month-old who's in for hypovolemic shock, who has a heart rate of 70 or 60, is not okay. And if he got to a heart rate of 50, I would start CPR. Okay? So bradyarrhythmias, you have to figure it out, right? So a heart rate significantly lower than expected. That's why we have to know in peds what normal heart rates are, okay? So heart rates less than 60. When they have all the normal parts of the heartbeat, okay? Now we start assessing. Are they altered in their perfusing? When I look at my blood pressure, what's my map? Is it over 65? Is the kid alert, mentating? Is the speech clear? Are they warm, well perfused, cap refill 3 seconds? This kid's not having a bradyarrhythmia. He should have bradycardia because he's really fit, right? So, when we see those unstable bradyarrhythmias, this is what's happening, okay? I had a kid in the PICU. She was a 5-year-old paraplegic from a car accident. She came in for a viral pneumonia. She was there for 2 weeks, so I knew her well. I took care of her multiple times. The extenders always did overnights. We showed up at 5, we left at 9 or noon the next day. It was a great shift. And so I came in and I'd had her several days in a row. She'd had whiteout on one lung, then she got a tension pneumothorax and had to have a chest tube. We fixed that, then she got whiteout on her other lung and it required intubation. So I was her provider that night while she was intubated, and the chest tube had come out. She had reinflated her lung. And for the most part, we were thinking she was fairly stable. So I'm getting a report, and when Shady Grove had their PICU, it was managed by the children's PICU. So ironically, the guy that I was getting a report from was the top doctor at children's PICU. So I'm always humbled in those situations because I know he knows so much more than I do. So I'm getting a report at the bedside, and we're going through all the systems, and I'm looking at everything, and I go around and I look at all my bed settings, and I come back and I'm looking at the monitors, and I looked at him and I said, I don't like it. I'll never forget it. I just said, I don't like it. And he goes, what don't you like? She's very stable. And I said, I don't know yet. I haven't had enough time with her, but I just don't like it. And it's right here telling me something's wrong. And he's like, oh, not another nurse's gut instinct. And I was like, yeah, but how many lives has it saved in your PICU, right? So I said, well, just go home. Are you going to be home? Are you having dinner? Do you have any plans? Don't go to the movies because I'm going to be on the phone tonight. And he's like, so he leaves, and I'm working, thank God, with a nurse named Sarah who had been a PICU nurse for a really long time, and she was very good. And so I'm going through all my assessments, doing all my things, looking at my orders, checking my meds, doing my job. And I looked at Sarah and I said, do you have a funny feeling about her? And she said, yeah, and I can't figure it out either. And I said, something's happening. I said, we're going to watch her very closely. I said, let's just do ABGs every 30 minutes. And she looks at me, 30? I'm like, yeah, I know they're stable, but just do them anyway. And so we started doing frequent ABGs, and every time I get an ABG result, I'd call the attending. I'm just calling in to let you know, these are her vitals, these are her ABGs. And he's like, why are you getting them? And I'm like, I don't know, I told you I have a sixth sense, and I don't like the feeling, and I haven't figured it out, and she hasn't manifested anything for me to be concerned about yet, but my gut's telling me something's wrong. So I did this for 3 hours. And I'm on the phone with the third set of ABGs, and nothing has changed. At this point, I think he's thinking to fire me in the morning because I'm the biggest pain in his ass in a long time. I'm on the phone with him, and I said, oh, here we go. It's so funny how we say things, right? I said, oh, here we go. I told you so. And he goes, what's happening? And I said, oh, her heart rate's 110. And he said, well, what was it? I said, 118. And he goes, and it's 110. And I said, oh, I'm going to be calling you back, and it's going to be 80, and then it's going to be 70, and we're going to be doing CPR. My money's on her coding tonight. He's like, all right, well, what are you going to do? And I said, well, I'm hanging up from you, and I'm calling a code. And he's like, how are you calling a code? She's sinus tac. I said, I'm calling it. Bye. And he goes, don't hang up. I'm the only one who knows what to do. Clearly, that's not true, right? You didn't think anything was wrong with the kid. So I'm not relying on you to save her life right now. So I hung up the phone, and by the time I pressed the code button, her heart rate was in the 90s. So the code team comes running up. It was from the PED, and Julia looks at me, and she goes, what's going on? I said, I have no idea, but this girl's going to die on us tonight. And she's like, well, that's helpful. And I said, I don't know if it's a chest tube. So I called for a chest x-ray. So I'm getting a chest x-ray. I didn't know if she collapsed her lung again. Her lungs were completely whited out. Anything could have happened. So lungs are fully inflated. You're listening. She's on a ventilator. We take her off the ventilator and are bagging her. And I hear no breath sounds. But on chest x-ray, everything looks normal. What do you think happened? Yep. She was throwing clots. That's what my gut was picking up on. And then she threw a massive clot, braided down, cardiac arrest, and died. So, you see bradyarrhythmias, it's almost always that kid's going to die, okay? So, your exam and NCLEX ask you at what point you do CPR on a child? Less than 60 in an infant, okay? Not an adolescent or a school-age kid, but in an infant and small child, less than 60. Yeah?
I guess I have a question about what if the patient is awake and their heart rate is less than 60?
So, let's talk about this. What's the mental status of somebody who's decompensating in the process of dying? I also told you she was ventilated. So what do we do to vented patients? Sedate them. So she was sedated. So she wasn't awake. So yeah, that was a terrible day. I was there for 24 hours because we couldn't get a hold of her parents because they were deaf. She was deaf. So yeah, so we sat staring at each other. What could we have done? That was a lot of fun. And I came up with one answer. She had no compression socks on the whole time she was there. She was a setup for a PE, being a paraplegic.
So would it be compression socks or SEDs?
She needed those,
SEDs.
yeah, whatever you call those things. She needed those compression, whatever those things are. Yes. Yeah, because she was immobile for like 2 weeks, and we weren't giving Lovenox or heparin, so we were setting her right up for a PE. So big shock when she threw one.
And then you can't see them.
You can't see them,
Because they're-
but your gut's like, what's going on? Something's happening. I don't like it. Her heart rate's 120, her heart rate's 140. What's happening? She was throwing clots.
So is that a normal protocol to give them, like, to do something like that? Like, why wasn't it
To do what?
do that?
Oh, it was a
SEDs or
normal
something?
protocol.
It is?
It is.
Yeah.
Nursing hadn't done it.
Oh, wow.
So is that like malpractice or
No, but
could you take it?
Patient abuse.
if they sued, we would have given them money.
Yeah.
So, bradyarrhythmias, if they're stable, you just do an EKG and consult cardiology. But if they're unstable, you're doing your airway breathing, right? Because a lot of times, just breathing for them will help their heart rate come back up. And then you do your algorithm, all right? Dress your H's and T's, your thermias, your tamponades, do your labs. All right, now the heart's beating too fast. Oh, sorry, I included H's and T's for you because you guys are new to this, but H's are your hypovolemia, hypoxia, hydrogen ion, acidosis, hypokalemia, low glucose, hypothermia, toxins, tamponade, tension pneumo, thrombosis like a PE, and trauma. Okay? You'll hear H's and T's in your senior course. All right, so Brady arrhythmias, right? P wave, normal QRS, ST, 1, 2, 3, 4. Sinus, Brady. Let's do tachyes. As we know, kids always have faster heart rates, right? So your toddlers have heart rates 100, 120. They live in a sinus tach. You know, I walk in a room and due to fear, now they're 140, right? They have a fever, they have pain. Very common to have a normal sinus tachycardia, okay? Tachyarrhythmias, we don't like, okay? Because those have the cardiac compromise. It's beating too fast, or like in the case of an SVT, it's not even including the atrias in that, right? So the two examples are SVT and VTAC, okay? And mainly the kids experiencing VTAC are kids with cardiac defects, okay? A normal healthy kid doesn't go into VTAC. So SVT, usually infants greater than 220, children greater than 180. P waves are abnormal or hidden, right? It's not a sinus driven. So here's your algorithm. And the biggest thing is how well that kid is perfusing. Think of that newborn that came in, they were hypotensive, tachycardic, tachypnic, hypothermic. I have to get that kid out of SVT. All of their bodily functions are not doing well. If they're compensated, we can do some other things. So here's an example of SVT, supraventricular tachycardia. Beating too fast, right? How about these? What's this one? So
SVT.
it's a sinus tach. What's this one? And this is of course VFib. Get practice. So VTAC. This is sustained VTAC. Right? We would synchronize cardio over this. This is probably a kid with a normal sinus that has a burst or a short run of VTAC. That's somebody you want to give some amiodarone or something to calm down the ventricles. Okay? So, you need to know this for your exam. Uncompensated SVT. Those kids look like crap. They're in shock. Poorly perfused, delayed cap refill, all of those things. You don't got time to play nice, okay? So you've got to deal with that and get them out of it immediately. So we're going to drop a line, give adenosine, and cardiovert as quickly as we can, okay? If the patient's stable and we have time, we can have them in a straw, which is like simulating a vagal maneuver. We can put ice to their face, and the shock of that it's like doing a cardio version, right? And then we can give medicine if that fails, okay? So we have to get him out of SVT. SVT leads to heart failure. It's just going like this, and there's not a lot that can happen, okay? VTAC will go to VFib into asystole if we ignore it. So it has to be treated. You do synchronize because it's a regular rhythm, and then we'll give amiodarone and try to figure out why they're having runs of VTAC. So you got to know how to deal with SVT. We see a ton of it. Lots of kids have even conduction issues like a Wolff-Parkinson-White syndrome, which causes SVT. So there's some days we have like 6-8 kids coming in and out of SVT, and we're like, all right, what's going on? All right, submersion injuries, drowning. They inhale water, okay? So you have profound problems with oxygenating. The lungs are like, in a tub of water. That results in pulmonary edema. So what does pulmonary edema look like in a patient? Pink, frothy sputum. Okay? So they're always usually cold. They're submerged in water. I had a 4-year-old, my last drowning was a 4-year-old. Mom had a baby 2 weeks ago, so family said, let's take him over to the family reunion. We'll watch him. You stay home with the baby. So nobody watched him. That's what happens. A word to wise, don't ever let your kids go to a birthday party involving a pool without you. Ever. Not one time. Okay? So anyways, nobody was watching him because you were watching him, but you thought he was watching him, and you thought she was watching him, and then nobody was watching him until everybody saw him at the bottom of the pool. So EMS is called, they come, they start CPR, he is dead when they pull him out of the water. So they start CPR, they get water out of his mouth, and they intubate him, and they start epi and all the meds, and they're doing CPR, and they come into my hospital, and I'm in the PICU, and I come running down to assist because that's what we do. And I'm working with the pediatrician, the only pediatrician we had on staff, and she was the one who said, you're on airway, I'll get you an IV access. Okay, because you don't trust yourself, which means I shouldn't trust you on airway either, so let me try it. So I go over to the airway, and I'm getting a report from the medic, and she's down there putting in an IO in, and I said to the medic, tell me the circumstances. I found at the bottom of the pool, pulled up, a little water came out of his mouth when we were doing compressions, and then I immediately intubated. How much fluid did you get out? Nothing. Okay. I take my stethoscope, I listen. I don't hear breath sounds. I just yank the tube out. The paramedic's standing there like his jaw hits the floor. I said, you're not intubated. I immediately intubate the child, and this shoots out the tube all over like the front of him before we can even do it bamboo bag. So I connect suction to it, and I just stand there, and I pulled off 400 cc's, and I called the code. 25 minutes they'd worked him. He wasn't intubated the entire time, so he was brain dead. Huh?
Could he have been saved if they would have gotten?
It's hard to say. I don't know how long his downtime was.
Can they even do that in the field where they do the stuff, what you did?
Yeah.
Oh yeah.
That's their job. Their job is to put that tube in the right opening.
So it was in the wrong placement, so the water couldn't come out to do.
They were not oxygenating anything. They were just blowing bubbles into his stomach.
Right.
Okay? So you have to get oxygenation. And if you don't, they die. Okay? Therapeutic management, we put them in a sea collar because we think they fell or hit the bottom of the pool. And then airway breathing is super important. Suctioning the airway, intubation is usually always needed with 100% oxygen. And then don't forget, we've got to warm them up because they're cold. We don't usually call a code until they're warm. So we have ways to warm with blankets and IV fluid warmer. And then NCLEX at great risk for secondary drowning and should be admitted for 24 hours. So even if I don't die from my drowning and I come back and I'm like, okay, and I'm fine and my lungs are clear and my pulse ox is 98%, you still get admitted. Okay? Because that secondary drowning takes time and you develop pulmonary edema from the toxic water in the lungs and the kids die in their sleep at home. Yes, Leah?
Is CPS usually called with these or no?
Depends. They're usually accidents. And like I have a pool and I couldn't like get my permit for my pool until Long Fence came and put up my fence. I couldn't access my pool. So drownings happen all the time. I sent all 3 of my grandchildren through what is it? Infant rescue, ISR, infant rescue, where you throw the kids in the pool and they learn to float. I have a pool. The in-laws have a pool. They have a beach house. We have a lake house. We're around water all the time. Ain't nobody drowning in my time. Not on me. Boys game. So, who tells us what to do? Because kids get into everything, right? So you can inhale something. You can get something on your skin, like a splash, or you can ingest it, right? There's a couple concepts here you need to understand. So let's work through these together, okay? So I come up and I find my kid, and he got in a bunch of medication. I go and call Mr. Yuck. This is Poison Control's number. Everybody who's a parent, anyone having kids in your home, that should be by your phone. You say, hi, I'm Heidi, I'm a nurse here at Frederick Health. I have Kim Hess, she just took a bottle of Motrin by accident. This is her name, her date of birth, her address, and her phone number. And she says she ingested 40 200 milligram tablets, all right? They're gonna tell me exactly what to do, not the physician. The physician will tell you to call them, okay? So they keep track of everything. They know every substance, all the treatment for it, whether or not they have to be admitted, whether or not they need cardiac monitoring. So as a nurse, you'll sit there and write down everything that has to be done, okay? And then you'll go to the doctor and say, this is what they need to be done, okay? The reason I give them all of Kim's information is they call Kim to check on Kim too, okay? But then they call me back and say, hey, how's Kim doing? Did she get the charcoal? How's she feeling? What are her labs? Did her LFT stay okay? What's her Tylenol and aspirin level, right? They are monitoring the case, okay? So, therapeutic management depends on what you're dealing with, okay? So you might have to wash the skin. You might have to, do different medications. So, these are the concepts for NCLEX that I want you to understand, okay? So, if I found Kim, who's now 5 years old, taking that bottle of Motrin, and she's sitting on the floor eating one after the other like they're M&Ms, right? I can grab her up, grab the pill bottle, throw her in my car, drive to Frederick Health, run in the door, and say, she just ingested this. What would you do? Charcoal, naloxone, lavage, or dialysis?
Call Mr. Yuck.
But Mr. Yuck's going to tell you what to do. So, I told you some key things in this scenario that you
Naloxone's
should
not
pay
going to do
attention to.
anything. So she just did it.
She just did it. I watched her do it.
Lavage.
100%.
Yeah.
I get her there within 30 minutes. I want to get all of that out of her. So that's an NG tube, a big fat one. And I'm putting water down and pulling it out and trying to get all of the medicine out as fast as I can. Have you seen those lavage tubes? They're like a garden hose. Okay? Then I'll give the charcoal for whatever I couldn't get out. But if I take a bunch of pills or something and I can get to the hospital within 30 minutes, you want to lavage that. Think about your, Montgomery County was famous for this. Think about your kids that are drinking alcohol, that are afraid they're going to get in trouble, so everybody just drops, Jada off at her mom's front porch, and she's just, mom comes out with her coffee in the morning, and she's like, what are you doing here? You're passed out unconscious on the ground. You call 911, you come in, I'm going to stick a lavage tube and try to get all the alcohol out of her as much as possible. Because that could save her from intubation, right? So if you get them in a timely fashion, get it out. Okay? Yeah, Bryn.
Is lavage what they say, like pumping your stomach?
Yes.
Is that the term? Okay.
So what you do is you put the big tube down, you put water in, you pull it back up, you
Right.
put more water in, you pull it back up, and you just keep doing that until it's clear. Yes.
Can you just for like first intervention simulate their gag reflex, try and make them throw up?
Depends on the age.
Oh.
So you want a lavage, but you don't want them to aspirate either. So most of the time we do things to them to do that. So lavage, if you can get it quick, right? Activated charcoal if it's been an hour or two. Activated charcoal is gritty. You got to keep stirring it. They've got to take a weight-based dose. And it goes in very messy, black tar. It stains your clothes, and it comes out the same way. But what it does is that medication binds to the charcoal so it's not absorbed, and then you poop it out. Okay?
And nobody ever drinks how much they should. It's like, what
It's
is it, like 2
awful.
grams per
My
kilogram?
favorite is to put an NG tube down a kid and just put it in. Naloxone to reverse narcotic ingestion. My first day cross-training to the adult ED, I had more fun than, and they still talk about it. So for fun, my friends put me on the go team, which means somebody outside on the hospital grounds is having a massive problem, so they need life-saving measures. So Nina Funderbug, the charge nurse in the adult ED, goes, "Come on, we're the go team." Well, I follow blindly because I love excitement. So I'm like, yay, we go running out to the front. Right in front of the emergency department entrance is a lady. A man and a woman were driving the car. In the back passenger seat is a lady. Not breathing. So we're like, oh God, she's like dead, So Ashley Joyers is with us, and you know Ashley. So Ashley's like, I've got an bamboo bag. And I'm like, thank God someone's prepared. It was comical. So she's like, she starts bagging. So she's reaching in the car like this, bagging the lady, sitting up. I'm like, I can't get access to her because now somebody's got a stretcher here. So I go around the other passenger door and open the door. And I don't know any better. I just climb in. I'm like checking a pulse. I'm seeing if we've got to do CPR. I'm like, what's going on? And I'm like, what happened? And they're like, well, we're here to visit our father. He's an inpatient in the hospital. I'm like, and this one? And they're like, we don't know. And we're like, huh? Powder on her nose. We're like, huh? Powder on the seat. Powder on me.
Oh,
Now I realize I'm kneeling in urine because she's urinated all over the car. Now I'm like, okay, I don't know, but I think we need some Narcan. Right? So I get myself out of the car. I'm like, I think I might have been exposed. I'm not sure. And I'm standing there. My scrub pants are soaking wet with her urine. Meanwhile, we don't got time to stop and worry about Heidi. We're getting her out of the car onto a stretcher. I'm blasting her with Narcan. Then she, by the time we get her back to 55, the Narcan's working. She's waking up. What are you doing? She's becoming combative. I'm like, what is happening? I think I need to go back. I'm just a peds nurse, I'm saying. It's wild and crazy over there. Sometimes they pull into the front and just need naloxone. We have it in a machine now in the entryway. Have you seen that? It's been all over. Yes. I have it in my office now. So, poisoning, naloxone, reversing narcotic ingestions, right? And then sometimes the kids end up on dialysis, but most all ingestions get admitted unless it's something minor, okay? All right, trauma is the leading cause of death in children from unintentional injuries. Car accidents kill so many kids. And what's so sad is it's a lot of times preventable. We just have to put them in the right car seat, right? Pedestrian accidents, these are kids hit by cars, hit on their bike. Sporting, bicycling injuries. We get a ton of trauma from four-wheelers in Frederick County. Like, I'm not kidding. Fractured femurs, head injuries, you name it. Kids don't wear helmets and they just fly like bats out of hell. And then we have a lot of firearms, so we even have kids that shoot each other. I know, it's crazy. Trauma in children. I wanted you just to understand the PMP process. So, when we're dealing with trauma or critically ill children, this is just a way we do the survey. So, we start with airway and alertness, and we're assessing all of those: alert, verbal, pain, unresponsive. We're looking at their airway, breathing, and circulation. Circulation and control of hemorrhage is next. Disability is the D, Glasgow coma, pupils, consider a head CT, check your AccuCheck. Exposure, remove clothing and inspect for hemorrhage, signs of trauma, and give you a blanket. We've done all that, and now we're going to get vital signs and bring the family in. Now we're going to do our labs, monitor if we need airways, assess the pulse ox and capnography, pain assessment. Now we're going to do our history, head to toe assessment, inspect posterior surfaces, and then come up with 3 anticipated interventions, and then the we just keep doing vital signs, identified injuries, primary assessment, and pain just keeps being reassessed. Okay? So really important with any of your kids in shock and some of these arrhythmias and everything that you're doing continuous assessment. Because interventions change outcomes. Okay? All right. For exam 4 and NCLEX, there's really only a couple things that they want you to know. You've already learned them, so I'm not going to teach them to you. But it's really these 3. So with autism, the biggest thing they want you to understand is that these kids do not develop normally. So when they're sitting like in a room, other kids might be doing parallel play, where this kid is off in the corner with his back to everyone, doesn't care what everyone else is doing because he's in his own world. So there's a lot of missed social cues, and they want you to be able to pick out a kid with autism for peds, okay? ADHD, these are kids like me, right? We can't sit still. We're super productive when we're adults, but boy, getting us through school is a handful, isn't it? Remember my first grade teacher, she said to my mom, Heidi's an excellent student whenever she's at her desk. And my mother's like, well, where is she? And she said, anywhere but at her desk. And so my mom's like, well, how good of a student is she? And she goes, well, you can answer that for yourself. And my mother's like horrified, right? But that was me my whole life. Get me to sit in my seat, I can pay attention, but I don't sit. So just understand the importance of that distractibility and impulsivity with kids. And then really high percentage of kids suffer from anxiety and depression, and we're going to talk about why next. Child maltreatment is a major problem. How many in here like to watch crime shows on TV? You ever watch things about serial killers and all these things? What is the one thing they all have in common?
Their mom didn't love them.
They're child abuse survivors. All of them had horrific childhoods. Okay? And that's the way they're described, as horrific. Their mother didn't love them. Their mother locked them in the basement. This, that, and the other. This is a big cause of the dysfunction. Remember I said if we could solve child abuse, we would solve the massive problems in the world. What is the fastest growing criminal enterprise in the world?
Trafficking.
Human trafficking. Okay? It's happening all over Frederick. Do you know that? Yeah. People are picked up off West Patrick Street for human trafficking in Montgomery County. There's human trafficking in your schools. So, this is from 2023. Nearly 8 million children were abused that year. 2,000 of them died. Neglect is the most common type. Children under 1 have the highest victimization. Parents are the majority of offenders. Look at us over there. 74% of us. And girls have a slightly higher rate than boys. All right, this lecture comes with a warning. I don't know about you, but I'm a child abuse survivor.
Yep.
Okay? And I'm a domestic violence survivor. So yeah, I have trauma. It's why I act a little wacky. You know, trauma stays in the nervous system of your body. So when my dad died, I said to my doctor last week when I had chest pain, and she's like, you know, you got to go to a cardiologist. And I said, this is just this. You understand, right? My heart hurts. It's allowed to be sad. And I told her, I said, you know, trauma stays in my nervous system. So when I go through something that's difficult, my trauma comes back up. Okay? Wow, we've got to stop abusing children. Okay? Physical abuse, emotional abuse, sexual abuse, neglect, poverty, bullying, natural disasters. What do I mean by that one?
Like house fires?
House fire, hurricane, tornado, 9/11. Do you know, I'm going to make up this number because I don't remember the true number, but it was something like $140 million was designated for the child survivors of 9/11 parents who died. Less than $1 million of it was utilized. We don't think to send kids to therapy who go through natural disasters, but they all need it. Okay? Basic hierarchy of needs of Maslow. Your basic needs are down here. We're not getting to self-actualization, coping, maturing if our basic needs are not met. So if we're living in poverty, I'm not coping, I'm just surviving. Okay? If I'm being bullied, I'm not growing and developing normally. I'm in survival mode. Okay? Domestic violence. Anybody here seen somebody be hit before? Shocking, right? You're like, what did I just see? What's going on? What if that's your normal day to day? The demeaning, the put down. I'm a DV survivor. I was married to a man who had a drug addiction. And anytime I got in the way of his drugs, he would beat on me. And I was the head of forensics. So, are there things in our behavior that we can pick up on that go, ooh, that's not normal? Ooh, I wonder if there isn't something going on that needs further investigation. Okay? So, sudden changes in behavior, withdrawn, anxious, depressed, aggressive, hostile, hyperactive. That's a change in behavior. That's not to say your kid's with ADHD, right? This is a kid that's not normally hyperactive, is bouncing on the walls, right? We have fear of going home or with a special adult. Can I tell you how many kids I could have adopted when I was head of forensics for Montgomery County? They all wanted to go home with me, okay? Behavioral extremes, overly compliant. I would have 3-year-olds just lay there in the lithotomy position, naked, with no care or concern. I don't even do that, right? I'm an adult. Changes in school performance. I'd have kids that were doing really well in school who became truant, whose grades started dropping. They started getting sassy and mouthy with the teachers. The teacher's like, I don't know what's going on with Jasmine, man. She was always so sweet and so smart. Okay? In age-appropriate behavior. 8, 10-year-olds start thumb sucking. Bedwetting is a really big indicator of sexual abuse in children. So these are kids that are potty trained, and now at 6 and 7 are bedwetting again. Okay? Changes in eating and sleeping habits, risk-taking or self-destructive behavior, lack of attachment. Think back to who's the abuser. 75% of them are parents. How am I going to attach to somebody that's wailing on me? Specific to physical, sexual, emotional, and neglect. Wariness of physical contact, shrinking at the approach of adults. Have you seen it? I've seen it. Kids cower. You raise your hand, they're like this, right? Inappropriate clothing for the weather. That's a big human trafficking red flag. Human trafficking, they ship you from city to city to city. So I can be in Dallas one day and in D.C. the next, and if that happens in January, I might have shorts and a t-shirt standing on the street in D.C. So inappropriate clothing was one of my big indicators of human trafficking on my screening tool for my doctoral thesis. Abusive towards other children and animals, we know that, right? We hear that all the time. Well, they started killing the neighborhood cats, right? And you're like, ooh. Sexual abuse, demonstrating bizarre, sophisticated, or unusual sexual knowledge. Kids that are sexually abused start age-based relationships much younger. So the 13, 14-year-olds start dating 18, 19-year-olds. They're already sexualized. So now, think about it. The 18, 19-year-old's going to buy them a cell phone, take them to the mall, buy them clothes. So, of course, I'm going to date the older boy, not the boy my age. He's got no money. Okay? Unwillingness to change clothes in public, social withdrawal, fantasy play. This is rare. In all of what I researched and did, less than 3% do fantasy play. Like Barbie's putting objects in locations and different things. Less than 3%. And not all of them are being sexually abused. So this one's kind of in. Poor peer relationships, running away from home. Why are you running? The streets are not better than your home. And if they are, we need to know what's going on. Do you know the only two? So when I get hired as an expert to go in trial and testify and give my expert opinion on whether or not that child was sexually abused or not, there's only two ways I can say for certain it happened. Well, three. You know what those are? Think about it.
STIs.
STIs. If I've got a 2-year-old with chlamydia, she shouldn't be having it.
UTIs.
No,
No,
it's
no, no,
STI.
no.
Think about it. Pregnancy. And if I was there and witnessed it or it was recorded. Okay? Otherwise, it's just my expert opinion based on the circumstances presented to me and my physical exam. So it's only STIs, pregnancies, and if it was witnessed or videotaped. Okay? So, emotional abuse. This is a hard one to quantify, and this one goes with all the others. Okay? It doesn't happen in a vacuum, right? So these kids are getting all the negative. You're worthless. You're a piece of... can't do anything right, right? And then neglect. These are kids, Maslow's hierarchy of needs. I need a roof over my head. I need food on my table. I need clothes on my back. Okay? So, if I don't have those because my dad was put in jail, I'm going to lie to get him back out of jail to meet my basic needs. So I've gone to court multiple times to remove parental rights from parents who are trying to do just that. Mothers bringing back offenders. One of my worst cases of child abuse, and one of the cases that got me to quit because the vicarious trauma associated with it was so bad. I was doing about 100 miles an hour in my car over Braddock Mountain down, totally oblivious to the cop following close behind me, just cruising down just to get home, tears coming down my face. I finally recognized the lights and sirens are for me as I'm pulling off our exit to come home. And I'm like, oh, he's following me. So I get over to the side of the road, and by the time he gets up, I'm just sobbing. And he's like, ma'am, are you okay? And I'm like, no, I just had the worst day. And he said, what happened? He was the nicest young guy. I said, the domestic violence lady's face, her whole face was purple. I've never seen anything like it. The entire face. She had no white skin on her face. And then her eyes were purely red. And then I said, and then my second case was a 2-month-old that was thrown up against the wall by the mother's boyfriend. And he's got a skull fracture, and I'm just sobbing. And he's like, ma'am, just follow me. And he police escorts me home. And I walked in the house, and I sat down, and I thought, I need a new job. I'm like, I'm going to kill myself, because I'm not even aware of cops following me doing 100 miles an hour on the way home, because I'm just sobbing over these cases I just had, right? This is really awful stuff to work with, right? So, yeah. Begging for clothes. What I was starting to say was one of the worst cases I had was that 2-month-old who was thrown up against the wall. It was my mother's boyfriend. He was 19, she was 32, and mom had 5 children. And so when the baby's abused, the most vulnerable of them all, what do you think's happening with the other 4? So he was sexually abusing all 5 of them. And so I opened up a full investigation on all 5 of them. She lost custody of all 5 of them. He went to jail for a really long time. And then next thing I know, I get a subpoena that she's trying to win custody back of the children. So I had to go testify for 2 days to shut that down. And then she went to jail and was pregnant. Abuse is terrible. Physical indicators of abuse: constant hunger, poor hygiene, they don't have the right clothes, they're tired all the time, right? Fear of abandonment. These are kids that are left home, mom's working, things like that. Sexual abuse: 90% of sexual abuse have no injuries. And I'm not going to tell you all of the details why, okay? But a lot of sex abuse of younger children have no injury. So it's based on story, okay? 98% of children who disclose abuse are telling the truth, okay? Emotional, they start having habits such as sucking, biting, they're do a lot of that. Conduct disorders, antisocial, neurotic traits such as speech disorders. And then physical abuse is easy to see, right? The long-term sequela of child abuse is bad news, okay? We miss work. We have, over the course of a lifetime, a single rape of a woman causes her to lose something like $225,000 over her lifetime of income from missed work, from somatic complaints, from therapy, from all the medical expenses associated with it. Violence is a very costly thing. I'm sure I'm not the only victim of violence in this room. So what I had to do was walk away from doing it 24/7. But I really charge you to be aware, to be surveilling, to always keep your eyes and ears open, regardless of what patient you're taking care of. Because I saw every bit as much elder abuse and neglect as I did child abuse and neglect, okay? So just as nurses know that we're charged to keeping our patients safe, if we see something, we have to say something. Every single one of you will be mandatory reporters. So if somebody says something or you witness something, you have to call and report it. And it's okay to do that. It's not that scary. You just dial a phone number and you say, "Hi, I'm Heidi. I'm calling from Shady Grove Medical Center. I have a kid that I need to refer to you. This is their name. This is their age. This is what I saw. This is what they told me happened. All right, thank you." It's their job to investigate, okay? I may be called again. I may not be, okay? But what if you don't make that call? Could mean the death of a child, right? All right, what we're gonna do next is break into groups and do some work, and I have to write up a couple more of these, so take just, what time is it? Now, take about 2 minutes while I write this down and then come back.